Hello everyone. Now we get back to Europe. I'm happy to present my friend Dr. Simon Chard, one of the most distinguished young dentists in the UK. Simon Chard qualified with honours from King's College London Dental Institute and in 2015 was voted the best young dentist in London and also the overall best young dentist in the UK at the prestigious Dentistry Awards. Simon has been a board member of the British Academy of Cosmetic Dentistry and has a strong focus towards achieving optimal aesthetic results utilizing minimally invasive techniques. Dr. Chard enters this program to talk about digital dentistry, which is one of his main focuses as an international key opinion leader for Dentsply Sirona. Simon is passionate about aesthetics and the linkage with the digital world and focus his clinical practice on that. He will be presenting CEREC workflows in modern cosmetic and implant dentistry, which is one subject that is part of our modern dentistry. Be sure you don't miss not even a second of his presentation. See you in a couple of hours.
Hi there guys, my name is Dr. Simon Chard and I'm here today to speak to you about digital workflows in modern cosmetic dentistry. I'd like to start off by saying a big thank you to the guys from International Aesthetic Masters. They've put together an absolutely fantastic raft of speakers here in a very innovative lineup, and I'm very proud to be here representing the UK. As I say, my name is Dr. Simon Chard. I'm a cosmetic dentist and I work in London in England. I sit on the board for the British Academy of Cosmetic Dentistry and I'm also a part of the Academy of Digital Dentistry. And today I hope to give you a little taster of the ways in which I'm using digital dentistry in my day-to-day practice as a cosmetic dentist. I work in southwest London in a practice that my parents have helped build over the last 30 years. My wife Megan and I, who's also a dentist, have now taken over the practice and we're taking it forward. We really think that it's going to become one of the world leading clinics coming from London, England. And this is me where I'm at my most happiness with my CEREC machine. This is the way in which I utilize digital dentistry. Now, the idea with today is not necessarily to say you must get a CEREC machine, but it's to show you the ways in which I'm using digital dentistry to help provide the best quality of care for my patients and to help them receive fast, efficient, high quality, highly aesthetic results in a time frame that works for them and in a way that's very enjoyable for me as well, and hopefully I instill some of that passion on you guys. This is me in my lab here as well. We've got a little lab on site where I stain and glaze my restorations, and I'll touch on that a little bit later on. So just as an overview of what we're going to cover, I'm going to talk to you about my journey with digital dentistry. I'm going to talk to you on the benefits of digital intraoral scans as opposed to traditional analog impressions. And then I'm going to show you the different ways in which I'm using digital dentistry. So how I'm using it in restorative and cosmetic dentistry, how I'm using it as a part of my orthodontic pathways, and how I'm using it for implant dentistry as well. And then also show you a little bit of how I'm using hybrid workflows, a little bit of analog mixed with a little bit of digital, to show you ways that you can be a bit flexible with it and use the best of both worlds. So what is CEREC? Well, CEREC is basically chairside economical restorations of aesthetic ceramics. It was invented by Mormon and Brandestini back in 1980, so it's been around for a long time. And as I say, today is not really a webinar for me to preach to you as to why you should be using CEREC. It's more for me to show you the way in which I use CEREC as a tool to elicit my digital dentistry workflows. But CEREC itself for me was the right choice. I wanted the ability to chairside mill as well as to have a highly accurate scanner. In the CAD/CAM world within dentistry, CEREC has been around for the longest, so it has the longest backing of scientific evidence behind it. And as I say, it really just ticked all the boxes for me. But if you use 3Shape, if you use Carestream, if you use any of the other scanners, they're very, very good. But for me, the workflow of being able to provide a chairside mill was what I was after. So digital, as I say, I used to put this slide up and say, why go digital? I think most people now realise that digital is the way forward, but you really can use digital in whichever discipline of dentistry you choose to niche down into. So if you're an aesthetic dentist, you can use that. If you're an orthodontist, you can use it there. If you're an implantologist, you can use it there as well. So the big question, are traditional impressions days numbered? Well, normally when I'm at a congress giving this lecture, I ask the members of the audience to put up their hands and say, when was the last time any of you wrote a handwritten letter to one of your friends? And a couple of people in the audience have put their hands up, but it's very, very rare that we do this nowadays. Most of us are communicating via email because it does the same job and it does it in a quicker and more efficient manner. And I believe this is the way that we're heading with dentistry as well. So what I'm going to do here is I'm going to compare the different workflows of analog versus digital when we are trying to create just a simple, straightforward crown on a molar, for example. So if you're doing it in the analog fashion, after you've done your preparation, which would be very similar regardless if it was digital or analog, you then choose your tray, take an impression, disinfect it, write up your lab docket and send it off to your technician. He would then trim the impressions, cast the models, set the pins, cut the models and then marginate it. And only at this point would he be able to tell you whether or not your impressions were accurate enough for him to make a high quality prosthesis from. At this point, if your impression wasn't accurate enough, you would get a phone call from your patient, a phone call from your technician, the phone call that none of us wish to receive, in which he would then be saying to you, Simon, unfortunately your impression is not good enough. You're going to have to bring the patient back in and take another impression, which is not something that either of you want to entertain. In that case, you then bring the patient back, have to numb them up again, take off the temporary, take a new impression and keep your fingers crossed that you get it right. So let's say you do get it right this time, your technician is then going to wax it up, he's going to invest it, layer it, polish it and glaze it and then send it back to you. And that workflow normally takes in the region of around about 2 weeks. Now, comparing the digital workflow, there are two different streams within the digital workflow. One of them is the chairside stream, where the restoration is being fabricated in-house by the dentist. Or alternatively, there's the laboratory stream, where you're sending it off to your technician and he's going to fabricate it for you and then send it back to you. Now, talking about the top stream, obviously this is a far more time efficient manner of doing things. You take your optical impression, you design the restoration, you mill it, which depending on your mill will take between 10 minutes to half an hour. You're then going to polish it and glaze it, and then you're going to fit the restoration. So in general, I will take around about 2 hours from start to finish to deliver the final restoration. If you're doing it in the with your laboratory technician in a remote location, you send in the digital data, he then receives it, and if you're in close collaboration with him, he can actually give you feedback on that straight away. While the patient's still in the chair, you can therefore make any adaptations to your preparation or ensure that you have better hemostasis if you didn't have that originally. And so this live feedback loop gives you a far better workflow, both for you and also for your patient and the technician, in that you can make those adjustments required immediately while the patient is still numb without a temporary on, and you can then send the accurate impression to your technician. Once he's happy with it, he can then design it and mill it himself in-house at his laboratory, and then he can polish it and glaze it and normally have it back to you within the region of around about 3 days. So it's a much faster workflow doing it with the technician. Obviously it's considerably faster doing it chairside. So if you compare those different workflows, it's quite clear that the analog workflow is a far more laborious and time costly workflow. Therefore, in my humble opinion, traditional impressions days are very much numbered, and I think most dentists now can see that is the pathway that we're moving forward on. As to when everyone is on board with digital impressions, I think we're still a long way away from that, but certainly in my office I very, very rarely will take a silicone impression nowadays. I am normally scanning for everything. The other benefit of this is that at the moment this does give your practice a unique selling point, a USP. Given that we all work in a competitive market, certainly from my patient's point of view, if they went to a different dentist now who wasn't using a digital scanner, they would feel that it was a step back to the older way of doing things rather than the new practice being up to date with the latest technology. And so I feel that it gives me a unique selling point. I think we forget very easily how busy our patients are and how little time they actually have for us to get the work done, and digital really helps me to provide high quality aesthetic restorations within a much shorter time frame. There's also a financial implication to this, a return on investment. These hardwares, the main reason why a lot of dentists haven't invested in them is because of the large initial capital investment. From my point of view, the reason why I wanted to be able to deliver chairside dentistry, one of the reasons was to get a return on investment on this large capital investment. And I believe that by having an average laboratory saving of around about £80 per restoration provided, quite a lot more for an implant restoration, and I'll come to that later. This helps me to regain some of the outlay that I've made on that technology, whilst also providing the highest quality of care for my patients. And it also generates excitement and intrigue. I've certainly never had a patient get excited about having a silicone impression taken, and I certainly don't get particularly excited about it either, but both myself and my patients do get a lot more excited about this technology. And all the time I have patients in the waiting room where my milling unit is located, as you can see on the right hand side of the screen there, on FaceTime to their wives, to their partners. Look at this, look how amazing this is, my crown's being made, and I really try and involve them in the whole process. And it just helps to really boost the interaction and the excitement that our patients are getting out of dentistry, which can sometimes be quite hard to do. So let's get into the clinical side of things. Chairside restorations, restorative dentistry. Let's talk evidence-based dentistry to start with, because a lot of people are concerned, or historically have been concerned, that the quality of the restorations that we're providing with CEREC aren't of sufficient quality. Now I'm here today to tell you that certainly anecdotally that is definitely not the case, but obviously we've got to support what we're doing with the appropriate data. Now this is one of my favourite studies. This is a meta-analysis by Hickel and Manhart. It's quite an old one now, but actually what it shows is the relative loss rate of a posterior restoration of different materials. Okay, so as you can see on the graph here, glass ionomer has the highest relative annual loss rate of all of the restorative materials that we have, and that goes down through traditional pressed ceramics, through gold, which obviously is traditionally our gold standard material for longevity, and then you see even lower than that is CAD/CAM ceramic restorations. Now that's a really exciting statistic for me. As I say, this study, the citation is at the bottom of the screen there, but it's a meta-analysis. So this is not a small sample study, this is a large study which really supports us using CAD/CAM restorations. Further to this same point, Baroudi and Ibrahim did a lit review in 2015 which compared a number of different studies on a similar topic, which is basically are CAD/CAM restorations as good as laboratory-made restorations, and they found a resounding yes was the answer to that. In my opinion, anecdotally, and I think this is supported by quite a lot of evidence as well, CAD/CAM is very, very good at providing restorations for very good preparations. If your preparations aren't smooth and they're very inaccurate, then it really struggles to get over those inaccuracies. And I think in those situations, a laboratory-made pressed ceramic restoration will be more accurate. But if you're confident in your preparation technique, you take time and care to smooth the enamel of your margin or smooth the dentine at the margin, and have a nice smooth internal structure, and you understand ceramics, then the results that you can provide for your patients can certainly be of as a good quality as from a laboratory-made situation. So let's move on to restorative dentistry and start with materials. Now materials, you may think is a bit of a boring topic. For me, I really love materials. I think the rapid onset of new materials, especially within CEREC dentistry, is really exciting. And obviously within CEREC, we're talking about monolithic materials. So we're not layering ceramics. This is a single phase of ceramic the whole way through. And that has positives and negatives. The positive of that is that because it's monolithic, it's very unlikely to fracture, or it's less likely to fracture. The negative of that is because it's monolithic, you don't get that inbuilt characterization that the technician layers into your ceramics, which means that you can lose some of that three-dimensionality, and thus you need to be a little bit case selective with where you use this and how you use it. If you have an extremely characterized upper central, it's very difficult to match that with staining and layering, with staining and glazing, sorry. If you have a bleached teeth or quite monolithic looking natural dentition, then it's very easy for you to match that with a monolithic ceramic. Now, these are it's not an exhaustive list of what's out there, but these are the sort of most commonly used ceramics. So you can see, moving from left to right, you've got the CEREC block, the Vita Mark II, which is sort of the most used block in CEREC dentistry. That's a feldspathic ceramic. You've then got the Empress Multi, or an Empress block from Ivoclar, which is a lucite reinforced ceramic. Obviously everyone knows Emax, lithium disilicate, which is right in the middle there. And then you have Celtra Duo, which is one of the newer materials from Sirona. That's a zirconia lithium disilicate hybrid. You've got Supridity from Vita, which is also a lithium disilicate zirconia hybrid. And then you've got zirconia on the end there. And the way that I've set this up is that as you move from left to right, as a rule you're getting an increase in strength, but you're getting a reduction in transparency. And that's why those blocks in the middle tend to be the ones most favoured by the majority of CEREC dentists, because it gives them that nice trade-off between translucency and aesthetics, but also a fantastic fracture toughness and strength. And that's why the bulk of my work is done in either Emax or Empress, depending on the loading situation. We also have the benefit of the hybrid materials. One of my fellow speakers at the International Aesthetic Masters is Francesca Vailati. I saw her recently at the British Academy of Cosmetic Dentistry conference, and she was talking a lot about hybrid materials and their fantastic wear characteristics. So they wear just like a natural dentition, and therefore if you're using them to treat a patient who's parafunctional, you find that they wear away at the opposing dentition far more favourably, and therefore they're very useful from that point of view. Aesthetically, then they don't match up with ceramics, but in non-aesthetic or less important aesthetic areas, they're a really nice material to choose from. And as you can see from left to right here, we have Vita's Dynamic, GC's CeraSmart, and 3M's Lava Ultimate. There are other ones that have come onto the market as well, such as those from Shofu. We also have provisional materials, CAD Temp and TelioCAD. These are extremely useful as a replacement for laboratory-made sort of medium-term bridges, and also for implant restorations that I'll come on to now. So using milled PMMA restorations like TelioCAD and CAD Temp have been shown to provide a really nice soft tissue response around implants if used for a custom healing abutment or a provisional, and I'll talk to you about that later on. We also have Enamic, Emax and Incoris, the zirconia block, which are all definitive restorations, and as you can see they've all got these holes in the middle, which I'll explain all about later on. With a lot of these restorations we have to furnace them, and these are the main two furnaces out there at the moment, the Ivoclar furnace and the Sirona Speedfire. The fantastic thing about the Ivoclar furnace is that you can crystallize Emax within 15 minutes, so it works into that same day chairside workflow. The zirconia Speedfire furnace is fantastic because it can sinter zirconia in 15 minutes, which is absolutely incredible. It used to take many hours to sinter zirconia, and now what they've done with the Speedfire is they've managed to make zirconia a feasibility within a chairside same day situation, which is very exciting. So let's show you some cases here. I'm just going to start with single posterior restorations. This is the bread and butter of CEREC dentistry, and it's what most of us are doing on a sort of general dentistry basis. This gentleman came to see me. There was secondary decay underneath this restoration. As you can see, it's fairly battered up. It's been patched up with composite on the mesiobuccal cusp. And so what we did is we prepared the restoration for an inlay-onlay. As you can see, full rubber dam isolation here. We've scanned the patient in onto our CEREC machine, and we've done a proposal, which looks very nice. We've then etched the preparation. Obviously, in the meantime, we've used hydrochloric acid and silane on our ceramic. And then I used the Verilink aesthetic bonding system. So this is the adhese from that. And that's our final restoration. So you can see aesthetically looks very nice. This is an Emax restoration. And there it is after the rubber down's been removed. So you can see aesthetically, if you match it to the premolar in front, it looks very, very nice, very natural. I'd certainly be happy to receive that from my technician. And as I say, that's an Emax HT block, so high translucency. So that restoration has been provided to my patient within the time frame of around about 2 hours. Far more affordable from my point of view. The lab bill for that was around about £35 for the block, and a much more unique and enjoyable patient journey, which will hopefully help to promote my practice to my patients' colleagues. As I was saying, one of the other great features of the CEREC technology is that it actually evaluates your preparations. As soon as I qualified from dental school, I was given a CEREC machine and said, this is what you're using for your digital dentistry. And it really helped me to learn very, very quickly how to improve my preparations. And this is one of the reasons why I'm hoping to get this rolled out into a lot of the universities, is to help young dentists to learn and develop their skills much faster, as I did using digital technology. This is an older case, but the reason why I show this case is to show how accurate the margins are here. We have the ability to modify our parameters within digital dentistry, and if your preparations are nice and smooth, you can get a very conservative preparation with a very precise fit at the margin. And as you can see, we've managed to save a considerable amount of tooth structure on the buccal surface there. But really, people say to me, do you really want to be taking the time to do these things? Why don't you get your technician to do it? Your time is better spent elsewhere. For me, it's an act of passion. I didn't need to add this hypermineralization to the cervical margin of this premolar, but really, I'm very passionate about providing highly aesthetic same-day dentistry for my patients, because I think it's a real win-win for everyone when they have that workflow and that journey for themselves. So talking a little bit more about the hybrid materials, as I mentioned earlier, aesthetically they leave a little bit to be desired, but it's their wear characteristics that they really excel in. They also have the ability to be milled very, very fine, so the edge stability, as we call it, is very accurate. You can see a comparison here between a Namec, Empress and Emax when milled down to a 0.3 thickness. It still maintains that edge stability, so that is one of the main benefits from a milling principle that we like very much. And you can see that on the scanning electron microscopy here. It really maintains that edge very, very fine. The benefit for us as digital dentists is we get a lot more mills out of one block of a Namec than we do out of Emax. The block is a lot softer, and so we actually we get around about 150 units milled out of a single set of burrs, whereas something like Emax you get more, sort of 30 mils out of a single set of burrs, and obviously that has a cost implication for us as well. GC's hybrid material, CereSmart, is, in my point of view, aesthetically a nicer material. You can get better aesthetic results, but still obviously nothing like what you can get from a ceramic restoration. And I'd like to talk a little bit, I'm not going to go a lot into the software today because obviously it's quite niche, but one of the tools that we have in CEREC is we have something called biogeneric copy. Now the beauty of this is it allows us to copy either pre-existing restorations or wax-ups of our patients, or even mock-ups that we do intraorally, which means that we can get a really nice aesthetic result in a functional way that the patient's often already test-driven. In this case, the patient had a re-root canal treatment carried out, and we had to put her into a temporary provisional restoration, and all we had to do when it came to providing the definitive crown was simply copy that crown and then deliver it in a ceramic restoration. A similar scenario here, we've got a gold crown that's had a re-root canal treatment carried out, and all we've done there is we've just copied the anatomy of that, which means that functionally we know that it's going to be very, very comfortable for our patient. This is especially important when it comes to quadrant dentistry. This lady, lovely Valerie, had some secondary decay underneath her existing metal ceramic crown. She also didn't like the appearance of these very dark premolars, and so what we've done here is we've simply copied the anatomy of these restorations into her definitive ceramics, and we've got a very nice result out the other end, delivered, as I say, on the same day for the patient. So let's delve more into aesthetics and talk about replicating nature with technology. One of these restorations here is a monolithic CEREC restoration delivered on the same day. Now from my point of view, all of the teeth that I can see here have a nice anatomy to them, they have a nice natural luster, and they have a nice translucency running through the incisal edge. And this case is Hilary. Hilary came in to see me the day before her 50th birthday. It was a Friday. She came in the morning as an emergency and presented to me as you see her on the screen right now. This was her workflow. So she had been temporized on, as you can see on the left hand side of the screen, by an emergency dentist, and they had just patched it up rather poorly in my opinion with some composite. So what we said to Hilary was, Hilary, don't worry, we're going to make some space in our diary and we're going to squeeze you in so that you can have your definitive tooth on your front tooth today, and you don't have to worry about it while you're giving your speech and while you're trying to enjoy your 50th birthday party tomorrow. So what we did is we prepared the tooth for an all-ceramic restoration. We did something called biogeneric reference, where we copy and mirror the anatomy of the contralateral central, which is a fantastic software principle that I'll show you the final result of. And then we've tried the restoration in the what we call the lithium metasilicate phase, so the purple phase that the ceramic is milled in. We've then stained and glazed it, and we've provided the restoration for the patient in a single visit. So you can see here, this is the biogeneric reference technology, and in this case the mesiodistal spacing of both centrals is slightly different, so it's impossible without orthodontics to get exactly the same result. But the technology has done a fantastic effort of trying to replicate the incisor ledge anatomy, the surface labial texture, and also the shape and the triangular nature of the teeth. So it's very difficult for an experienced technician to replicate that anatomy accurately, and the software does it very, very quickly. So that's one of the benefits of using this technology here. And you can see the final result is really, really nice. Fits into the patient's smile very nicely. And she was absolutely thrilled with it, not having to go through her speech with a temporary crown on the front tooth. And you can see really fits into her smile nicely. And even at a very macro level, like you see in front of you here, you can see that the anatomy is really nice and natural. If I'm going to be super critical, I could have polished back the glaze a little bit at the cervical. It's a little bit rough there, but this is a little bit of an older case. But you can see that even under this high scrutiny, with a monolithic restoration, you can provide very, very nice aesthetic results. And there it is again from the side angle there. Although we have monolithic restorations, we do have what we call multi-layer restorations, and one of these is Empress Multi, and it basically has a gradation of chroma through the block, which is really, really nice for aesthetic anterior cases. Slightly weaker than EMAX, so I don't tend to use it in parafunctional cases. But you do get a really nice aesthetic result with it if the substructure tooth is of a nice shade. And this is a case of a veneer replacement, very, very difficult. Veneers of different colours, the patient didn't want to change them all. So what we've done is we've just replaced this single veneer. We've taken the old veneer off, and as you can see, a nice smooth preparation there. I like to use these white stones from Shofu that I just modify to the shape that I like, and I use that to smooth the restorations at a very slow rate with lots of water, but it gives you a really nice polished restoration and polished margins. So we've taken the patient from here to here, and in this case we haven't glazed it, we've just polished it, and I think the luster looks very nice and natural. Another case of veneer replacement here, this is the lovely Jo. She, as you can see, has got some mesiodistal width issues again, so we're going to try and even out the widths of these centrals. We've taken off the old ceramic, and this is something that I believe in very, very strongly, is making sure you polish your preps, especially if you're doing CAD/CAM restorations. This is really important, because if you have any sharp line angles, you're going to be in a situation where the restoration may not necessarily fit. I love the soft flex disc for this, and obviously the white stone that I've discussed already. So this is our final preparation. There's a fixed retainer attaching the two centrals behind there, and as you can see, we've packed some triple O cord down into the sulcus. And what we've done here is we've actually added a little bit of composite on the mesial of the upper right one as well. And we've used Empress Direct composite there with an Empress Multi block. So we've really tried to keep some harmony between those two teeth. And again, what I've done here is I've polished the restoration. I'm tending to do this a lot more now, is trying to steer clear of the stain and glaze where we can, because it gives sometimes a rather unnatural shine to the teeth. And just go through a very specific polishing sequence, which tends to get a really nice aesthetic result once you've got saliva on the teeth. So you can see here, this is the sort of three-stage approach, and as I say, what I've used is Empress CAD, Empress Multi, with Empress Direct composite. So using that same chemistry to try and achieve a nice aesthetic, even result. But sometimes we don't want to provide everything chairside. This was quite a difficult aesthetic case, and when we don't want to do things chairside, we want to use our digital technician, which is incredibly important. The digital technician is going to have such an important role to play over the next coming years, because as people start to use this technology more, they need someone with a lot of experience of the technical information, how to use different file types, what's going to work, what isn't going to work. And I have a fantastic digital technician, a gentleman called Eddie Marku, who I work with very, very closely. And this is a case that I worked on with him on. And the way that we do that with CEREC is we use something called Sirona Connect. So we scan the patient in, we draw the margins, and then we fire that directly to the technician over the internet. They get a text message or an email saying they've received the file, and then we can chat while the patient's still in the chair about that scan. So Robin came to see me. He wanted an aesthetic improvement. He wasn't happy with the appearance of his teeth, and he wanted veneers. Now, if you look at Robin's case, he's got a very, very large diastema. He's got tetracycline staining, and he's actually already had some bonding on there to try and close that diastema down. So what I said to Robin was, you're not a good case for veneers without some pre-restorative orthodontics. And most of my veneer cases tend to have an element of pre-restorative orthodontics, unless they are replacement cases. So in Robin's case here, what we've done is we've gone very multidisciplinary. We've decided to do some fixed orthodontics. This was done by my colleague, Dr. Yasmin George. And basically we've evened out those spaces so that we can provide ceramic veneers upper 5 to 5. The patient didn't want a long period of orthodontics, so what we've done is we've kept the time frame of the orthodontics down to around about 5 months, so that we've got enough space to provide a highly aesthetic restorative result. We've then carried out some tooth whitening. This was with Enlightened tooth whitening, and we've got quite a nice result with that, which is going to help reduce our preparations as much as possible. We've used the Gorel technique, so we've done an additive wax up where we've tried to minimize the preparations as much as possible. And these are our final preps ready to scan. So what we do now is we scan the restorations onto our CEREC machine, and we fire those straight over to Eddie, the technician. These are the scans that you can see in front of you here, ready to go. And what we do with that is Eddie actually gets a 3D printed model, and the reason why he gets this is he's still going to mill these restorations, which I'll show you in a second, but because he's going to cut back and layer them, he needs to have a physical model that he can work on the contacts and check the aesthetics on. And so he needs to have a 3D printed model. So what he's done here is he's got one that's sectioned so that he can take out the individual dies and check on the contacts where he needs to. And these are very high-end 3D printed models, and they need to be extremely accurate. The quality of 3D printed models is very, very important, and it ranges dramatically from printer to printer. So this is Eddie's rough digital smile. As you can see, it's not completed. That midline's obviously not complete there. But what he's going to do here is he's going to use this, mill these in full contour, and then cut them back and layer some Emacs onto the labial surface to get a more refined aesthetic result. And here's the final result here. So you can see really nice characterization built into the teeth, something that you'd never be able to achieve by purely staining and glazing these restorations. Lovely translucency from within the teeth there, and as you can see, he's put some lovely texture onto these teeth. And this is something that I recommend a lot for dentists who are doing chairside restorations as well. Even if you're happy with what's come out the mill, try and add a bit more character to it with some recontouring, add some more surface texture. It just makes the restorations look more natural and puts your own blueprint on it, as my colleague Phil Reddington likes to say. So this is the before from Robin, and this is what he looks like at the end. So a lovely aesthetic result, as I say, done in as minimal way as possible, utilising technology but also utilising some analogue features there as well. And this is his before and his lovely happy smiley after photo there. So really, really nice result. We were thrilled, he was thrilled, and it was done in a really nice fashion for him. So talking more about orthodontics, I do a lot of sort of as I mentioned before, pre-restorative orthodontics, but also just simple Invisalign and what we call anterior alignment cases. And using digital scans for this makes my workflow and my patient's workflow a lot easier. And I'm going to show you a few cases of how I do that now. As I mentioned already, I do a lot of Invisalign treatment for my patients. I only treat adults with orthodontics, and I find that Invisalign's a really nice workflow for that. And these are the sort of scans that we're getting out of what we call the CEREC ortho software. So really nice, very, very accurate scans. And actually, Sirona have shown that the rejection rate on these scans by Invisalign is far less than that from traditional impressions, as long as the correct scanning technique is utilised. So really, really nice impressions, and this is my standard digital workflow now with Invisalign. So what we do is we take digital photographs, we do a digital scan, and we then create a ClinCheck for the patient. And we can get the patient's aligners to them really within about a week, so we can make the whole workflow a lot faster for the patient, which makes it just means they can get started a lot quicker. I do a bit of fixed orthodontics as well, again just really dealing with anterior aesthetics. This is a case, Ramanit, who came to me unhappy with the aesthetics of her anterior teeth. So again, same workflow, digital photos, full intraoral scans. As you can see, it gives you a really nice representation of what the bite looks like here as well, which is very useful for restorative cases. Ramanit's case is going to be what we call an align, bleach and bond case, so orthodontics to get the teeth in the correct position, followed by some vital tooth whitening, followed by some, in this case, cosmetic bonding. And these are my orthodontic labs that I work with here, so we send that off to them digitally. And we convert this intraoral scan into this 3D print. The lab then makes us some indirect bonding trays on top of that, and we use those to position the brackets perfectly within the mouth. We then carry out the orthodontics. In this case, I think it took about 5 months worth of orthodontics to align these teeth. Carried out some tooth whitening, and then, as I say, some cosmetic edge bonding to create a very nice smile. And you can see from that before and after, a really, really nice aesthetic final result, done in a digital fashion. If you like using incognito lingual braces, you can use it for that as well. And there's also some very clever softwares out there for digital bracket placement, which if that's the sort of treatment you like to provide, it can be done fully digitally, which is really, really nice. Another way which I find them very, very useful to use digital on a regular basis, especially when the patient's in fixed braces, is taking a quick scan while they've still got the braces on, and you can then get a lovely retainer fabricated on that digital scan. Now you can either do that completely digitally, you can actually get CAD/CAM milled wires, or what I tend to do to keep costs down for the patient is I actually get a jig made in the sort of analog fashion, made on the digital 3D printed models. But regardless, what it means is that you don't have to take impressions of the patient while there are still brackets on there, which is a very laborious and messy business. It's a far simpler workflow to do it with digital scans. And that's done by S4S, I think, in my case here. So I'm going to talk to you a little bit more now about ways in which I'm using digital in slightly more unique fashions. This is Paul. We wanted to do an aesthetic improvement for Paul. He was moving to LA. He was worried about the function and the wear on his front teeth. And what we decided to do here is use a digital wax-up, an analog digital hybrid workflow to provide a really nice aesthetic result for him. So as you can see from the scan on the left-hand side of the screen there, he's got pretty severe wear. The incisal plane's been really worn down there. We've carried out a digital smile design, created obviously by Christian Coachman and Olivia Yoshinga. So we've done a digital smile design on him. The reason being here that we're going to lengthen his teeth. And actually, he's already got quite long teeth. So we wanted to make sure that we were working within the correct length to width ratio and providing him something that was going to fit harmoniously into his face. And you'll see at the end that although we lengthen the teeth within his face, the final result really looks fantastic. So as you can see here, quite discoloured teeth, evidence of some fairly severe parafunction. You can see across the incisal edges of the anterior teeth there's quite a lot of wear. And so we've obviously taken some digital scans and a full set of photographs. And in this case, we're not going to get an analog wax up done. Okay. Again, as I mentioned before, the bite gives us a lovely bit of information that means that we're going to be able to increase the length of these anterior teeth without raising the vertical, which is very, very useful for us. So in this case, Eddie, again, my technician, has done what we call a digital wax up. So he's taken this digital file and he has done a digital representation of the final result using the digital smile design to help guide him. And so what I can do with this now is get it 3D printed. This was printed with the Formlabs, the Form 2 printer, which a lot of my colleagues have got. And I'm going to use that 3D print in the traditional way, in the same way that I would use it for a cosmetic bonding case with an analog wax up. So in this case, what we've done is we get full rubber down, the patient's completed his tooth whitening, and I use that 3D print, take a silicone stent of it and use that to guide the length of my cosmetic bonding procedure. In this case, what we've used is Tokiyama Posterior composite, very nice aesthetic composite. And this is our full digital flow. So digital photo, digital scan, 3D digital wax up, 3D print, and then the final result done in Tokiyama Posterior, as I mentioned before. So this is the before for Paul, and then this is his final result. And as I say, you could be forgiven for thinking that potentially those teeth were too long. Actually, they're just at the upper end of what we view as being aesthetic. So there's 85% length to width ratio, which is just within the sort of 75 to 85 that's recommended. But when you look at it in his full face, as I'm going to show you in a second, this is just a little video. I like to take these before and after videos to show the patients. It shows a lot more emotion within the smile. In Paul's case here, he speaks quite quickly, so it's quite difficult to catch a glimpse, but it looks fantastic. And when you see the full face, you can see that thanks to the digital smile design, it really fits into the smile very, very nicely and fits into the face very nicely, which obviously from the patient's point of view is the most important thing. Now, what some of you may not have noticed here is that actually Paul's got quite a considerable midline shift, but because we have kept the facial midline in line with the dental midline, you don't see that. If there had been any cant there, it would have been an aesthetic disaster. But as Garel mentions, you can stay within 4 millimeters of the midline in a vertical plane, and actually aesthetically it's not a big compromise. So Paul was absolutely delighted.
Hi, I'm Paul. I came to see Simon probably around about 2 months ago. I had a bit of an issue with grinding, and cosmetically I wanted to improve my smile. While I might have been slightly apprehensive at first, Simon and his team did a great job at making me feel really comfortable with everything, and the end result has been amazing. So following a cosmetic whitening and then the composite build, I'm really delighted with the outcome and would have absolutely no issues in recommending Simon and his team in the future.
So really nice. I do these with all of my cosmetic cases. Really nice to get patient testimonials, video testimonials, which you can use for your marketing and use for your website and that sort of thing. So as you can see, Paul absolutely thrilled with the final result, and all done with a digital frame of mind, but using some analog techniques. We could have done that case in ceramic, but we wanted to try and keep costs down and also test drive the bite and see how he got on with it. So another digital case here. This is Catherine. This is a case in progress, but I wanted to show you how useful taking a digital scan is to a more complicated restorative case. As you can see here, she's got a fairly tragic aesthetic situation with regards to the smile. Very, very pretty lady, but the smile's really letting her down. Massive asymmetry, and when you look inside the mouth, you can see how it gets even worse. We've got real parafunctional issues going on here. And so what we've done with Catherine is we've taken those digital scans, we've sent one of them to our laboratory to make a COSMETIC programmer, and we sent the other one to Eddie again to get a digital wax up done. So again, with the digital smile design, we send it to Eddie and he gives us a motivational mock-up, which we can then use to place over the patient's smile and show them what the final result's going to look like. So the beauty of this is we take one scan and we can send it to as many different technicians as we need to get the final result. There's no duplication of models required or sending it to different individuals depending on what you need from them. So this is the before and after here with the trial smile for Catherine. As you can see, again, aesthetically, this fits into the face fantastically. This is purely additive at the moment, so it's probably slightly too far to the buckle, but it gives you a really nice example of how the digital smile design, again, has worked in the smile. And this is a close-up here, again, just to really show the patient what the final result is going to look like. This is a restorative orthodontic implant case. So it's a very complicated treatment plan, and we want to make sure that we're on the same page as the patient right at the start. So you can see a really nice aesthetic result there. Now finally, I'm going to talk to you about implantology and digital implantology. This is one of the topics that I'm most excited about. It's an area where digital can really shine, and hopefully I get you as excited about it as I am, because I think it's got a lot of benefits over the analog workflow. So this is what we work with when we're dealing with digital chairside restorations. We have a tie base at the front here. The grey little hat is a scan body, and then at the back there you have what we call the meso block. And the tie base actually fits within the meso block and has an anti-rotation lock in it, which means that they fit together perfectly. Now, as I mentioned earlier, we've got lots of different blocks at our disposal for implant retained restorations. On the left hand side of the screen we have the TeleoCAD, the CAD Temp, they're both milled PMMA restorations, Vita Anamic, which is a hybrid restoration, and then the Emax, obviously lithium disilicate, and then zirconia. We can provide both screw retained and also cement retained restorations, so different blocks will provide different things for you. And with regards to the cement retained, as you can see, I've sort of pre-crystallized the anatomical abutment here to show you the difference, but the beauty of this is that because we have a tooth coloured anatomical abutment, we can keep that just equigingival on the labial, and then anywhere other than the labial where aesthetics aren't as important, we can actually bring that supragingival, and that means that cement cleanup, if we do have to go cement retained, is far easier, and you're far less likely to get perisymentitis. So I'm going to show you a case here. This is Camille. Camille came in with a missing lower right 6, and what we did here was we placed a Megagen AnyRidge implant and restored it with an immediate temporary. Now, we did this at the time in an analog fashion. I would now do this immediate temporary with a milled PMMA, following a digital scan at implant placement, and I'll come on to that a little bit more later on. But in this case we did it with traditional Luxatemp and a temporary abutment, and you can see after 3 months of healing we've got a lovely soft tissue profile there. Now, I can't highlight enough how important, especially with digital, but in general implantology, having some form of temporary there prior to going to the definitive restoration is for getting the best soft tissue around your implants, and therefore, in my opinion, giving you the best chance of long-term success from that implant. Having this nice soft tissue footprint here made my life so much easier when it came to designing this restoration. So in this case, we're going to place the tie base, the scan body, which we use to scan the location of the implant, and then this is our digital design here. So we're designing the restoration, as you can see, within the CEREC software to fit in aesthetically and functionally into the smile here. So we mill the restoration out of a solid block of Emax. In this case, we're doing screw retained. Now we have another advantage here if we're able to try this in the pre-crystallized, pre-glazed state, which means that we can adjust that if we need to before glazing it, so the final restoration is fully glazed. So we've tried that in, we've adjusted the occlusion, and we've now gone ahead and stained and glazed it. Okay, so we stained and glaze it. We then bond that ceramic to the tie base. I won't go through the actual ins and outs of that now, but that bond is very strong. And we now have a screw retained tie base restoration ready to go into the patient's mouth. So in she goes. That's it at an insertion, and obviously we now have a screw hole to deal with. So what we do is place some PTFE. I actually hydrofluoric acid etch the ceramic access hole, and we then add some composite. So in this case I've used Venus opaque composite, the yellow tip, either OLC, OMC, ODC, light, medium or dark composites to block out that. Those opaque composites are very good at blocking out that grey hole. And in this case, because I really wanted to get a fantastic aesthetic result and I had such nice staining and glazing in the ceramic, I've just tried to replicate that using the Venus colour kit as well to try and replicate that staining. So you can see here, this is the final result, and from the occlusal you can see that you can't really make out the screw hole anymore. Obviously I have the photographs if I need to go back in there again to have any problems with the screw. But it's a really nice aesthetic result that both myself and the patient were very happy with. And again, this has been delivered at the restorative phase in a single appointment. So you're really cutting down your appointment times for the patient as well, which is fantastic. We've done a placement and immediate temporization and then gone straight to the definitive restoration. So from the actual clinical restorative point of view, it's 2 appointments. And that's our final result, screw retained, and a very nice restoration. That's our total workflow there, as I say, in the single appointment. Now, sometimes what we want to do is provide provisional restorations for our patients. In this case, TeleoCAD is probably my preferred material. TeleoCAD is a milled PMMA, and as I discussed earlier, people like Marcus Blatz have been doing some really interesting studies on how the soft tissue responds around these milled PMMAs compared to the chair-side fabrication of temporaries. Now, depending on your initial stability, you can either provide a implant provisional restoration or even a custom healing abutment to make the most of how the soft tissue heals around these to shape our tissues as much as we can do. These are the materials that we've discussed already, and actually the way that this is milled is done with carbide burrs instead of diamond burrs, and you get a really nice smooth finish out of it straight out of the mill. This is without any post-mill customization with a burr. So this is an example of a case. This is Sue. She came in to see me like this, and we went ahead and placed an immediate MegaGen AnyRidge implant. I would do this slightly different now. In this case, what I've done is I've placed just a regular healing abutment. Now what I would do again is scan the patient in on the day of surgery and provide a milled PMMA custom healing abutment to give me the perfect soft tissue profile. That would have saved me an extra stage of going through the provisional restoration, as I'll show you now. But in this case, what we did is we took off the healing abutment. As you can see, soft tissue footprint not big enough for the tooth that we're trying to replace. And so what we do is we scan the patient in using the tie base, and we then provide her with a milled, again, TelioCAD milled PMMA restoration. Screw retained, of course, and we then screw that down, and you can see the blanching on the tissues there. And we're going to leave the patient in that for a couple of months to allow the soft tissue to mature, so that when we come for our definitive restoration, we can provide a very much better emergence profile for the patient. Now the benefit here is what we can do is we can actually mill the restoration before the patient comes back in, and we can deliver that to the patient in a far faster appointment. We don't have to rescan. We can actually just mill the restoration in the same design as the temporary, but in a more definitive material. So we've milled this in Emax, again monolithic, low translucency Emax for the implant blocks, and we've got a much nicer footprint to work off there. So we then come in, try the restoration in quickly, and after 10 to 15 minutes we stain and glaze it, and it's ready for delivery. So again, it's exactly the same protocol as I showed you before, bonding the tie base outside the mouth onto the ceramic, access cavities filled, and stained and glazed to try and achieve a nice aesthetic result occlusally, and fits in naturally with the patient's dentition from the labial surface. So this is James. James came to see me. He had an implant placed by another dentist. And what I want to show you with James here is the use of the scan post. So again, we've scanned James in, and we've provided him with a milled PMMA provisional restoration. But what I wanted to show you here is how useful this is for controlling the emergence profile in anterior implants. Now these restorations can have composite added to them, just like traditional chairside fabricated temporary restorations. And so you can control that cervical height of the gingiva even whilst providing a milled restoration, which is really nice. But it's that subgingival emergence profile control that I find to be so useful for our digital restorations. And as I say, that's all done with TelioCAD. And there it is in position. Obviously, aesthetically, could be improved. What you can do with these cases is actually take an impression of the labial surface, cut it back, and then use some enamel composite to layer the incisal edge, which is an alternative way of improving the aesthetics for your provisional restorations, if that's something that you are into. Now finally, I want to talk to you about Jenny's case. This is a multiple implant case done with the same workflow. But again, what we've done here with Jenny is we've placed a couple of MegaGen implants in the lower right 6-7 region, and we've done this in an analog fashion, so we've used an analog guide. I would do this now digitally. We've placed MegaGen implants, and these are the surgical pictures. Very nice implant system. As you can see, placed slightly subcrestally. And we've used PTFE sutures there, which I highly recommend. Really nice soft tissue profile. And what we've done here again is we've just placed larger healing abutments. This is the patient 3 months later, ready for restoration. And as you can see, quite a nice soft tissue footprint here, not perfect, but quite nice. So we've elected to go ahead with the definitive restorations. I'd probably go through a temporization phase for this now. Again, place the tie base, scan it in, same workflow as you've seen so far. And these are the final restorations. Again, we try these in the lithium metasilicate phase to make sure that the occlusion is perfect before we glaze the restorations. Through the stain and glaze again, bonded onto the tie base, and then there's a definitive restoration. So as you can see, really nice aesthetic, long duration results there, and this is 1 year after placement of the restorations, and they're looking really, really nice there. So as you can see, a really nice way for you to restore your implants. You can take that one step further and actually use your digital plan, merge it with a DICOM file from a Sirona CBCT, and use that to guide the placement as well, which is a very, very nice way of doing it. You can then either mill your guide using the CEREC mill, or you can send it off to CICAT for them to make very, very nice, accurate guides for you, and they guarantee the accuracy of those guides, which for anyone who knows a lot about guided surgery is incredibly important. August de Oliveira has very kindly donated me a case just showing this workflow. This is an upper premolar case. As you can see, he's merged the intraoral scan with a CBCT scan. He's then milled a CEREC guide to help him guide the placement of the implant. He's done this fully guided using his keys, and 3 months later he then comes back, scans the restoration in, and provides a monolithic Emax restoration. So you can see really nice, well guided, well planned workflow there, delivered in a time efficient way. And just to finish, just to talk a little bit about what I view to be the future of digital, CICAT is a really exciting company owned by Sirona, and they are bringing in some fantastic new advances into areas of digital where we've traditionally struggled. So one of those areas is cases where we have to increase the vertical dimension, or cases where we're completely reorganizing the occlusion. There are no easy ways to be completely digital without using traditional face bows, waxing up traditionally on an articulator. Now, CICAT function, what it does is it actually gives us that information about the patient's movements of the mandible, and therefore in essence gives us that digital face bow. So it's a really exciting bit of technology. You merge that with the CBCT and the intraoral scan, and you can get really, really nice really nice accurate functional records from which you can then build your case. And you can even mill or have 3D printed some very, very accurate splints from this as well. CICAT Air is a way that we can use these scans to work within the sleep medicine field. As I say, it's not something that I deal with very much, but I know a lot of doctors are really interested in this. And it's an evaluation of the airways using the SL CBCT scanner to help guide your sleep medicine cases. And finally, as I've already mentioned, the CICAT implant, which is a very, very accurate way of merging DICOM files with STLs or CEREC files to plan your implant cases. So I'd like to thank you all for listening. If anyone has any questions, all of my details, I'm usually on Facebook or Instagram, but you can find me an email. And I'd like to thank the guys from the International Aesthetic Masters again for inviting me to speak. Hopefully it's been informative and educational, and thanks again from London. If anyone's ever in London, please do give me a call.